Hello, everyone. We're going to get started. Thank you for joining today's webinar, Structural Violence, the Role of Poverty, Trauma, and Stress in Mental Health and Addictions. I would like to begin by acknowledging that CMHA BC Division's office, where Jenny, Vanessa, Kendra, and I sit, is located on the traditional unceded territory of the Musqueam, Squamish, and Tsleil-Waututh Nations. Now, before we launch into the content of today's webinar, I'd like to point out a few features of the technology we're using and quickly run through the agenda. First of all, there are two options for sound, either your computer's audio or telephone. We have an international audience today, so you'll find 3 toll-free numbers for Canada, United States, and Australia. Please ensure if you choose the telephone option that you dial into the number for your location. You also have the option to switch from computer audio to telephone or vice versa at any point during the broadcast if you need due to technical difficulties. Second, we will be recording today's session and posting the video online at beforestagefore.ca alongside a PDF copy of the PowerPoint slides. You also have the option to download the slides at any point during the broadcast or afterwards before closing the window. The file is located in the handout section of the panel to your right. You may also notice that we've included CMHA BC's 2018 Poverty Reduction Submission as a handout for this webinar. In response to the BC government's plan to create and implement a province-wide poverty reduction strategy, CMHA BC composed this submission outlining a series of recommendations from improved cross-system coordination to housing and income supports to better address British Columbians' economic security and by extension their mental health, well-being, and recovery. If after today's presentation you're interested in learning more about the kinds of supports and services that lift people out of poverty and keep them mentally healthy, I would encourage you to download the PDF and read the submission in full. Okay, now on to the agenda. We are joined today by Jenny Morgan, the Director of Indigenous Health at BC Women's and Children's Hospital, and Vanessa Brcic, a family physician and registered therapeutic counselor. In their presentation, they will discuss how income equality, unstable housing, and discrimination are all correlated to poor mental health outcomes, what structural violence is and how it is experienced, and how we can reorient our healthcare system to better respond to patients' needs, providing trauma and violence-informed, culturally safe, person-centered care. A bit about each presenter. A member of Gitxsan First Nation, Jenny has dedicated her career to building trusting and meaningful relationships with Indigenous communities, striving to elevate their voices and advocate for their needs to affect systemic change and improve health and social outcomes. As a leader in health system coordination with an extensive background in social work, she weaves reconciliation and institutional accountability into policies and standards of care. Vanessa, in addition to being a family physician and a registered counselor, she is also a community-based researcher and teaches at the University of British Columbia. Her work is centered on safe and compassionate care for vulnerable patients. Through both clinical practice and research and advocacy efforts, Vanessa strives to put in place an integrated, person-centered model of care that provides patients with wraparound supports from housing to medical treatment. After the presentation, there will be an opportunity for audience members to pose questions. Please type your questions into the questions section of your panel to the right. I'll then read them out to the presenters at this time. If you would like to address your question to either Jenny or Vanessa specifically, please make a note of this in your submission. We'll try to get to as many of your questions as possible before the end of the webinar. And please don't hesitate to submit your questions. You can do so at any time throughout the presentation. In fact, the earlier you submit them, the more likely it is that it will be asked and answered by the presenters. Okay, without further ado, Jenny and Vanessa, I'll hand it over to you.
So we'll just have a look at this presentation outline. We're going to cover the SEOH and structural violence, trauma and violence-informed care, embedding cultural safety and humility into all health services for First Nations and Aboriginal peoples in BC, and the impacts on personal and clinical approaches. So we're going to start with brief introductions of why each of us are interested in this topic, what we're talking about today. And for myself, as was mentioned in my bio, I'm in a leadership position in a healthcare setting, and my interest and passion is around the momentum that we see here in BC to embed cultural safety and humility into health services. So I do have a strong interest in that, and do find it very rewarding when we have partnerships in place to make this happen.
And I'm Vanessa, and this interest really came to me from my clinical background. I've always had an interest in working in poverty reduction, including in the nonprofit sector before moving into medicine. And then in medicine, working in addictions and mental health and chronic pain, I really started to see the adversarial environments that people were in consistently, as well as underlying trauma from the past and present ongoing that people were experiencing. And then, of course, you know, the most meaningful learning for me was in my own recovery after a serious accident that was really disabling. And that really was the most important learning that I had, as well as from my family, who were displaced peoples, and I'm the first generation. Our family did not grow up in poverty, so I'm very conscious of the privilege that I have, and so it allows me to see patients through that lens as well. You can go next slide. So we wanted to start by framing our conversation, which is very focused on systemic and structural conditions, but we wanted to frame it in relationship to mental health and addictions. And so I'd encourage you to have a look at the Venn diagram on the top right of the slide, and recognizing the interrelationships between mental health addictions and underlying violence and trauma. This excerpt comes from a discussion paper from the Center for Excellence in Women's Health, which is a really useful document for food for thought. And I think, you know, the last sentence in this excerpt indicates, and this is from the United States, but still, that women with co-occurring disorders, virtually all of them have a history of trauma. And we're starting to see that more and more, that if we look upstream, we can see the vulnerabilities that people have accumulated in their lives that can perpetuate ongoing health issues and ongoing experiences of struggle and marginalization. Next slide. And the way I like to envision this is in the diagram below, because it gives us a visual to frame how we can act. So you can see that this person is on a slope, pushing this heavy ball of health hazards and prevent it from crushing them, basically. And the way that I see intervention is in three ways. So we can stand next to that person and help them push that heavy ball back up the hill. We can reduce the size of the ball by treating illness, reducing morbidity, using medications and our traditional biomedical interventions. But probably the most powerful intervention we can have is by reducing the slope that ball is rolling on. And that slope below consists of the social determinants of health. And this is not an exhaustive list by any means, but it does give you a visual to show you how cumulative adversarial experiences, barriers, and disadvantage can make that struggle so much harder for a person. And so when we're envisioning our responses, both clinically and also on a policy level, I think it's really important to see all three parts of this diagram, and not focus our efforts so much on just helping that person hold that ball up the hill, because I think that's where we often end up in a clinical environment, and yet we can have such profound action if we start to address the slope of the wedge, if that makes sense. And then an additional factor that I added on this slide was support for the chronic stress response, which is a healthy response to having to deal with stress for these conditions listed here and others that are not listed as well. And then we wanted to also offer a definition of structural violence, because this really frames the presentation. And this photo can be seen as a metaphor. It was taken by my partner when we were on a road trip, and he noticed the violence in this image, and I found it really meaningful to reflect on all of the different ways that we can see this concept as a metaphor around us. But I'll offer these definitions. These come from Paul Farmer's work, and the two references at the bottom of the slide, as well as on the other slides, provide some really useful readings. I'd encourage you to look at the references that are listed here. These are very dense but very meaningful reads, especially the first one that's listed at the bottom of the slide. But I'll offer these definitions to start. So structural violence as political, economic, and social structures that disregard values and beliefs and result in silencing and marginalization. And I really would encourage you to remember those words, because they'll come up later when we talk about clinical approaches. What happens then is marginalized groups are left with little power, and the power they do have is constantly challenged and contested. And so you can see how already we're starting to see an echo of the chronic stress response in this definition. Structural violence includes also colonialism, past and present, and any condition that perpetuates discrimination, oppression, or stigma. It can include a host of offenses from relative poverty to extreme poverty, social inequalities from racism to gender inequality to many more, and greater forms of violence. And what's interesting about this last sentence is it causes me a lot of cause for reflection, because structural violence is exerted systemically and therefore indirectly by everyone who belongs to a social order. So this asks me to ask myself, how am I perpetuating violence, either by participating in a system that may be exerting violence indirectly upon a person, or even by mainstream clinical practices that we kind of adopt without questioning. And later on, we're going to see a quote called resisting the righting reflex, which is the desire in healthcare to always fix the problem, and how that can even take power away from people. So I think it's important to just reflect that, wow, I'm part of a system, and that system may not be safe for people. And so what can I do? Did you want to add anything, Jenny, to the structural violence?
Yeah, I'll talk a bit more about it in terms of in practice, but what you mentioned about self-reflection, that actually speaks to a lot of the cultural humility in practice of self-reflecting on one's own profession, and acknowledging how brave you have to actually be to actually recognize what's wrong with the system, how are you perpetuating these wrongs in practice, but then looking at what needs to change and being a voice for that.
So people impacted by social inequities are also often experience multiple forms of violence, not just one. So structural conditions themselves can increase the risk of interpersonal violence, and the more stress and violence and oppression people face, the harder it is for them to access supports to improve their safety. And so the model to address this has been described in really beautiful work by the EQUIP team, which is cited at the bottom of this slide, and which we refer to in this presentation, and which they have published as trauma and violence-informed care. So you'll see this coming up throughout the presentation. And what's important about this term is that it doesn't locate the problem in the psyche of the person. So it goes beyond trauma-informed care. It's not the person who is pathologized here, but the problem of trauma exists in the system, in the acts of structural violence. Next slide. And this is a reference slide with a website to link to the EQUIP Healthcare website, where a lot of their materials are available. And I would just draw your attention to the colorful Venn diagram in the top left, and in particular how trauma and violence-informed care overlaps with other related concepts: inequity responsive care, contextually tailored care, and culturally competent care. And so there's a lot of language that is used that describes this work, and strategies are outlined in great detail for organizations on how to implement this strategy. And so some of that is in this diagram, but really this is a reference slide for you to be able to access their resources.
So when we're talking about trauma-informed and violence care practice, I think it's important to kind of take a step back and look at the system to put all of that into context when we're talking about individuals that have experienced violence and trauma, and put into context how did we get here. And if we look at this document that was signed in 2015, it was 5 regional health authorities, 2 provincial health authorities, and the Deputy Minister for the BC Ministry of Health who signed this declaration, and it was to embed cultural safety and humility into all health services in BC. And so this was signed by the CEOs of each health authority. So it's the highest level of leadership in health to actually have a collective voice to show that there's this gap in our health services that needs to be addressed, and we're all in agreement that we're going to do this and work together to bring about change. And if you get a copy of the declaration, you'll see that it's creating a climate for change, engaging and enabling stakeholders, so all those involved, and implementing and sustaining that change. So from an Indigenous point of view, it's really about having meaningful relationships and sustaining change so that it's not just these one-off initiatives and projects, but it's meaningful change to the system. And speaking of momentum, so building off of what has happened from 2015, for those working in health, I've fall under these 23 health regulators under the BC Health Regulators body. This is a similar document I was signed. It was a declaration of commitment, again, to embed cultural safety and humility into the regulation of healthcare professionals. And if you go to their website, the BC Health Regulators, you'll actually see a document that was published earlier this year, which is a one-year report of their achievements since signing this declaration. So again, each of these leaders in these colleges are a collective voice of leadership that is identifying that we need to start working together to embed cultural safety and humility into these services. And so this is just taking a more careful look at understanding and recognizing when we're saying cultural safety, what is it that we're talking about? So on this diagram, you'll actually see sort of a spectrum and a journey of different points that you can reflect on of where you might be at or where your system or workplace is at, and what is the direction and aim that we want to go. So this goes all the way from cultural destructiveness, cultural incapacity, cultural blindness, cultural pre-competence, cultural competency, and then cultural safety. And we talked a little bit about racism earlier and social determinants of health, and I just wanted to add a note of why this is unique for Indigenous peoples, because that's really when you look at it more carefully at the system level, there's systemic racism as well as the day-to-day racism that we see in practice that Indigenous peoples experience. So this begins to actually shift the power imbalance in healthcare. If you look at definitions of cultural safety, you can find that in some of the different documents that I mentioned. But what they identified is that cultural safety is acknowledging the inherent what's inherently wrong with the healthcare system, rather than where we have come from, where there's this pathologizing of Indigenous people that there's something inherently wrong with them, and this othering that takes place. So it's creating this, addressing the imbalance, and we'll share a little bit more on that in this presentation. But we'll just look again at the next slide. That again shows you the spectrum of often where you'll be able to identify where your agency or organization is at and what the goal is. And understanding that this is a lifelong journey, that wherever you identify where you may be at, there's always a next step to keep moving forward. And when we're talking about sustaining change in the healthcare system, again, that goes back to meaningful ongoing relationships with Indigenous peoples when we're embedding cultural safety into our practice.
And so drawing a link now to some research that has been done on a social determinant that really caught my attention a few years ago. This is David Williams' work out of Harvard. And you may be familiar already with the links between health inequality, income inequality and health outcome. And that is very strong, and it's been shown in population health literature for decades, and it's really compelling work. But what really fascinated me was that independent of economic status, experiences of everyday discrimination is just as strong of a predictor of greater barriers in health and poor health outcomes. And so here's some of the studies that show the link between experiences of everyday discrimination and health outcomes. And I find this really powerful because this gives me a place to act. Sometimes, economic inequality feels like an issue that's really big or maybe outside of the scope of biomedical practice. And everyday discrimination is something that I can work on every day. So this is helpful work for me. Next slide. These quotes come from a qualitative study where women are describing their experiences of seeking care. And this helps us bridge into more clinical approaches. But I'll read these quotes and then we can talk about why they're important. So these are two different female patients who describe their experiences in healthcare. One woman says, when she speaks her truth and says, this is the way I'm feeling, I'm told that it's different than what I'm experiencing. The doctor told me it was all in my head and it was phantom pain. He said it was a post-traumatic disorder from my sexual abuse when I was a child. I'm sorry, I can't digest that, I can't, and I'm having a hard time with it. I'm really angry right now. And so this is, again, perhaps a caution to how when we start to recognize early trauma and experiences of adversity in people's lives without a well-informed and safe approach to respond to it, it can perpetuate violence for people. The second woman says she lost her children to doctors. There was no one believing how they got hurt or injured, and then she lost her little children to the ministry. And this is a beautiful study to read. It's really powerful stories, and I think these stories are really important to help engage us as healthcare providers. Did you want to add anything to that, Jenny?
Yeah, I appreciate these quotes because I think it really speaks to the challenges, and as I mentioned, like the imbalance of power in services that we see, and the question would be then how do we rectify this? How do we move forward and begin to bring balance of those voices that are involved and the stakeholders involved?
Next slide. And we come right back to language here, which echoes Jenny's slide with the ladder. This is a snapshot from a beautiful one-pager from the EQUIP team. The link is listed below the site here. I would encourage everyone to print it and put it up in their workplace. But we can see how ubiquitous that language in dark blue is in the healthcare system. And even by shifting to the language that's in white, where we refer to people as people and not as a patient or at risk or a user, and how powerful that shift in language can be to start to shift our perspectives and to shift the relationship. Next slide. So we have a couple of slides here on cautions as we move into clinical approaches. And there's something that I noticed, certainly in my own experience as a patient, but certainly in also working with complex populations, which is the way that our biomedical approach works is, we target our treatments for patients based on diagnoses which divide people into multiple body systems, multiple pathologies, and multiple diagnoses. So it's very easy with a complex patient to have a very long problem list, right? And this can actually perpetuate discrimination. It can perpetuate the sense of multiple barriers and doesn't help us necessarily in the healing approach. So I think it's really important to be conscious of that structural condition that exists above us. The other thing that I've noticed too is that, we work with what patients come with us to, what they describe, the stresses that they experience, the symptoms that they have, and yet adversarial experiences are stored in the body as stress response system. And this has been described as a term called implicit memory. Implicit memory are the deeper areas of the brain where adversarial experiences and the programming that has happened in our nervous system has been stored. And we don't have clear links between that and the executive functions and the rational centers of the brain. So it's not so easy with cognitive processes for patients to describe the impact that their adversarial experiences have had on them. The way that those experiences manifest is often through emotional responses and sensory motor responses. And so we treat those as symptoms in the healthcare system, and yet it's important to recognize that there is an underlying condition and that we are really treating downstream without recognizing upstream contributors to that ongoing stress response.
And this is just a slide again, going back to the definition of understanding around cultural safety. And one thing to keep in mind is cultural competency is about the reporting of healthcare providers, reporting the progress that they've made, what they've done to increase their capacity, enhance their practice. But when we're talking about cultural safety, it's actually, again, going back to balancing that power where it's, in this case, it's the Indigenous peoples reporting that they feel safe accessing health services. So in order for a service or a health provider to say that they're culturally safe, it's the patient who will define did they feel safe accessing health services.
And so back to the experience of chronic stress and why safety and shifting the power imbalance is so important. Really, the focus of our work is on safety, and we'll get to that in the coming slides, but this is why it's so important. So first of all, the brain has a tendency for the negative. So a great quote is that the brain is like Velcro for the bad and Teflon for the good. Negative experiences really stick with us, they become imprinted, and this is biologically something that every human is. It has come from our evolution to be able to avoid threats and survive as a species. And yet, if you have ongoing toxic stress, extreme stress, or traumatic experiences, it can really amplify that response. It can perpetuate the chronic stress response and get people stuck in a survival mode. Keep in mind that the fight, flight, freeze response is a healthy response to an experience of threat. So when people present with symptoms that are in keeping with a fight or flight response, it helps me to recognize, oh yes, this is their body actually doing what it's supposed to be doing. Now, at the same time, when we're in a survival response, our body is really focused on basic function, basic survival in that mode. And our executive functions of the brain that help us with long-term planning, decision making, and choice, all of those are basically offline. Similarly, when you're in fight or flight response, you're not in a place of human connection. You really need to be in a relaxed parasympathetic state to be able to really connect with people, which is why I think the practice of achieving safety with people takes time and takes deliberate effort. And I think it really helps to understand the physiology behind a person's response to why they might be resistant to coming up with a plan to stop using alcohol or tobacco, cigarettes, when they're in actually an active stress response in that moment. And then it's important to recognize in that last bullet as well that implicit memory, so where our deepest wounding and trauma is stored, is not easily accessible by the executive functions of the left brain. And yet, that chronic stress or fear pattern is programmed into people's nervous systems and can be awakened at any time. So people are naturally vulnerable to be triggered, to feel unsafe in healthcare and other threatening environments. And this is actually a normal response to stress. And I think that's really an important framework, that these patients are not responding abnormally. It's not a pathology. It's the body having adapted to a lifetime or recent experience of stress. Next slide. And so a couple slides just to kind of give you a clinical picture of what this looks like. So when a person has experienced a certain threshold of trauma or violence or adversarial circumstance in their life, that natural flow, that gray line that you see between nervous system activation and a state of perhaps calm or even withdrawal, that natural fluctuations that happens every day in response to normal stress can be amplified. And so it switches to this kind of red line response. And what can happen is, for example, if people have had a certain number of stressors, they get stuck on or they get stuck off. And this, again, is a nervous system coping pattern. But if you look at those symptoms listed in the two boxes in the top right and in the bottom left, we can see how a lot of patients come in with these kinds of symptoms. And so to try to see it as, oh yes, there is the stress response happening here, and this is normal and healthy for them. And it's actually, you can validate that, and that can help diminish the ongoing stress, perhaps by adding a pathology or a diagnosis to their list. We certainly want to treat and help them, but recognizing and helping them know that their body's actually adapted to respond to stress can be a very validating thing for people. Next slide. And this has been relatively newly described in the last decade or so as a central sensitization response. And what this describes is simply the body coordinating a stress response, and how that is linked to all of the disorders that are listed on this slide may help us understand how taking a nervous system perspective might help us approach some of these conditions. Similarly, ACEs, of course, stand for adverse childhood experiences. And this diagram shows population attributable risk in relationship to various clinical conditions or experiences that people might have. And we can see what an impact it does have. When people have had significant stress and adversity in their life, how it does manifest as challenges later in life. And those are what we're presented with in clinical in clinical practice. So recognizing the importance of trauma here is important as well. Next slide. And then briefly on post-traumatic resilience. And I think it's important to bridge to this because people develop resilience when exposed to risk or threat. And so there's also an opportunity that we have here, which is to spring back and to help patients do that, having had experiences of extreme stress or trauma. And resilience is defined here as a relationship between risk and the protective factors that counteract that risk. So clinically, we really want to work on, as Jenny said, shifting the power imbalance and build on their strengths-based, build on a strength-based approach in order to re-empower people towards resilience. And I think one thing that really stood out to me in recognizing the experience of Indigenous peoples in Canada is that not only the trauma that Indigenous people have experienced, but also that they were deprived of tools of resiliency, including traditional practices, institutions, and rituals, which help them and other societies to cope with trauma and stress and reconstruct identity. So when you cause trauma and then strip away one's ability to cope with it, I recognize the significance of that impact, and I certainly feel grief about that for the ongoing systemic barriers as we start to shift the balance back to power for Indigenous peoples in seeking care. Did you want to add something?
Yeah, I'll just add a comment to that. I think it's really important to understand intergenerational trauma and what's happened and where Indigenous peoples are now. But speaking to that, the fact that these protective factors were removed for Indigenous peoples to promote resiliency, that the resiliency in the Indigenous peoples still flourished. And I think that really speaks to the strength of Indigenous peoples, considering everything that's happened in terms of the ongoing colonization of Indigenous peoples, that there's this continued push forward to address these things.
Mm-hmm. So I briefly want to take you through, to close the presentation, this is a piece that I wrote for UBC Continuing Education called Trauma is a Determinant of Health. And it goes through 4 steps that we can go through clinically to help. It's not so much implementing trauma and balance-informed care on an organizational level, but working more on a one-to-one patient level. And hopefully it'll help bridge some of the conversations we're having around structural and systemic issues to opportunities in one-to-one clinical care. Go ahead to the next slide. So first of all, safety is our first priority. As we've seen, a stress response is a state of physiological overwhelm. So we want people to feel as not overwhelmed in clinical encounters with them. We want them to feel safe and calm. And I find for me in practice, that's about slowing down, not rushing. That's probably the most critical intervention to provide a non-overwhelming, lower stress environment for people. And also, as Jenny said, it's not just creating a climate for change in our structural environments, but it's building meaningful relationships. And a safe relationship that you can build with a person is probably the greatest resource that you can contribute to as a provider. And so really being attuned to that and really saying, in a visit, this is my goal. I really want to make sure we're on the same page, that I understand where this person is from, and feeling a sense of connection and safety, rather than being so focused on tasks and referrals and problem solving. We really need to validate the importance of building a safe relationship. And then as Jenny said too, shifting the power imbalance, we need to give people the opportunity for choice and control. Experiences of marginalization, oppression, and trauma, what's common in all of those is a lack of choice and control. And so we can work on a small scale in the present time and give people choice and control in all of the decisions that they're making around their health care. And then identify when they're able to do that. Identify the coping mechanisms that they have and the ways that they're actually able to cope, because there's always something that people are doing, because their brain is programmed to notice the negative. And so we can help them notice even a seed of strength that they might be demonstrating. We want to resist the righting reflex as healthcare providers. We don't want to fix everyone's problems, because then we're maintaining the power relationship. So we have to notice that impulse to need to fix everything. Certainly we want to support the person, but we want to be really aware of that impulse as healthcare providers to do that. And the way we can do some of this in clinical practice is working with boundaries, being really clear about what a patient's boundaries are around their care, being explicit about their preferences, and respecting their choices. As I mentioned before too, we want to normalize their symptoms. Like a lot of what people present with is actually a normal stress response. And I find that I spend so much time clinically validating people's experiences and the way that their nervous system is actually demonstrating a coordinated, healthy response. And it's a totally different lens to look through. And I find that patients right away come down from a stressful place to be like, oh, my body's actually doing what it's supposed to be doing. And now we have to practice together to help it feel safe again and to help it coax it towards a path of safety rather than its programmed path of fear and stress. As you saw in the previous slide as well, implicit memories and long-held experiences of stress involve either hypo or hyperarousal. So this can look like shame, depression, or a freeze response, or fear, rage, anger, and anxiety. These are all survival responses, and it's helpful to point out that that is a normal thing. And it's also helpful to expect it, and we'll get into that in the next slide. The other thing too is that when people have a strong physiological response to stress, or a strong trigger response even, they're not in a position to be able to perhaps integrate what you're saying, to modulate and control their physiological response, and their communication, connection, and executive functions are limited. So we have to understand that this is the baseline that people are coming from, which makes listening very important, and the kind of goals and actual next steps and action plans that we're making with patients really, it's helpful. The more simple they are, the better. The more resonant that will be for somebody who is actually in a stress response. We need to expect that healthcare is an unsafe space for people. And this is not only because of the institutional and colonial history in Canada with respect to our hospitals. And there's a great reference there, a book by Maureen Lux on the bottom right for anyone who's interested in reading more about that. And as well as ongoing racism and discrimination. And there's lots of descriptions of that being acknowledged by professional associations across Canada in healthcare. But even illness alone involves uncertainty, vulnerability, navigating complex mazes of services, and brand new relationships and environments. So if you look at that list alone, that second bullet, you can see that that is already going to put a person into a state of stress and vulnerability. And so it's actually quite normal for a person to have a feeling of lack of safety and a feeling of ongoing threat as they're seeking healthcare services. And I tend to expect this in people. And also finally, work in the present time. You know, people have all kinds of experiences in their past, and we are so capable in the present moment of going through these steps, of creating safety, of giving a person power and control back again, and working in the present moment. Next slide. And finally, it's important to recognize that we can't really separate experiences of stress out. So past experiences and present experiences, they're all activating the stress response. So we can act in the now. And I think it's important to remember as well that the problem is not the person. As you can see, the person is actually engaged in a normal physiological response, and that often the problem is the environment. And that's why we really wanted to focus this presentation on upstream contributors. And really help us develop a lens as healthcare providers that give us permission to act there. So in order to be able to act in the present time, given environmental stressors that are ongoing, we can develop action plans to increase safety and supports right now. And that includes looking at ongoing stressors. We may not be able to rectify an adverse childhood experience, but we certainly can help a person get more secure housing, get better income support through applying for disability or other appropriate benefits, accessing better sources and cheaper sources of food. There's so much that we can do in the present moment to help a person feel safe. And I really think it's important to make the bridge to that present time action. And finally, this is a link to one of multiple poverty tools that are available for clinicians. So this is traditionally not the work of family doctors, but increasingly making action plans for patients that are really relevant to their conditions of living as a primary concern of patients is so important. Like, I don't know what I'm going to do for a clinical condition if the person doesn't have a safe place to go back to, a safe bed to sleep in that night. And so we really need to legitimize including social determinants action in our clinical environments. So this particular tool gives you some prompt questions to ask, some opportunities for figuring out what resources might be appropriate for that person. And I build that right into my clinical approach with people that I see. And the link is at the bottom to be able to access that tool. It's specific to BC resources. So that's it. Here's our contact information. Please feel free to email us if you'd like to be in touch, and we'll put it back to the organizers to go to questions. Unless, Jenny, did you want to add any closing comments?
No, it was great. Thank you.
Well, thank you both so much. We are opening it up to questions from the audience. So as a reminder, please type your questions into the question field. It's in the panel on your right. You can do that at any time, and then I will pose them to Jenny or Vanessa. But we actually have our Senior Director of Policy Planning and Government Relations in the room, Kendra Milne. So Kendra, did you want to get us started? Do you have any questions for Vanessa and Jenny?
I do, and I hope it's not putting you both on the spot too much. But the discussion around kind of normalizing the stress response and creating kind of a safe, calm atmosphere really relates to some work we're doing right now around kind of the results of what we think are our mental health system sort of not providing enough services upstream. So many people in BC access services through kind of crisis care and often involuntary care. And we know that that can be really traumatizing for people. So I'm just wondering if you have any thoughts on how, or ideas on how we can kind of improve that caregiving relationship with people within that context where they may be actually receiving treatment involuntarily.
Did you want to?
Does that put you on the spot?
I don't know. You have to tell us if it's one or the other. Maybe.
Yeah, I'm happy to hear from either.
I guess thinking about service providers and provisions that are made, I think it goes back to building trusting relationships. When I think about some of the work that we're doing at Women's and Children's, as an example, like we will come into high stress situations with where patients are at. And we do have a support service available for Indigenous patients and families. And we always encourage the healthcare teams to engage that support right at the onset so that the trusting relationship is in place if or when a stressful response was to arise. And that relationship is there to help mitigate it. And also, we are having conversations too with our team that talk about what could different responses look like. And we work very closely with Elder Roberta, who will give examples of where she's come into very high stress situations and her role in that situation to actually de-escalate the stress that's arisen. So I think it can come down to the relationships that are in place and how can those actually help mitigate the stress that's emerged, whatever the case might be.
Yeah, I really appreciate that vision. I'm kind of imagining like a baseline safety, a baseline supports that are available to persons so that if they are kind of pushed beyond a threshold of safety or comfort, and we would expect the person to be triggered or have a tough response in that situation, that there's a resource, that there is something that's familiar, something that's safe that they can access. And similarly, like we can't abandon the principles, like even in involuntary admission, giving the person small opportunities for choice, and really like in a respectful way, not in a superficial token way, and asking them and really bringing in what feels safe for them. I think that person needs more support. If they're facing more stress, they simply need more support. So we need to figure out ways of doing that in the present time. And it's the same principles, like we still can respond to people in a calm voice. And there needs to be authentic connection, because I think in healthcare, we sometimes speak down to people. We really abide behind this wall of institutional policy. Like we know better. We know you need to be admitted. You don't think you do need to be admitted. And as much as possible, even given the circumstance of involuntary admission, we need to take that wall down. It's critical. Otherwise, we are perpetuating that lack of control, and that can be harmful for people. It'll take time to recover from that too. And I think acting also in between those admissions, like if a person is having involuntary admissions, that's a huge signal for me that we really need to build more safety and support in between to prevent it from happening again. So, and there's opportunity to act there too.
Thanks so much. We'll move on to a few of the audience questions. The first one, an audience member asked if you could clarify the terms upstream and downstream and how they relate to symptoms versus historical trauma.
So, so I'll start with that one. The way I picture it, and thank you for asking for clarification on this. When I see downstream, I think of symptoms. When people come into the doctor's office or into a clinical environment, they come in because they're not sleeping, they're not managing at home, they're having symptoms that are bothering them. And part of the natural practice in healthcare, I think, is to be like, okay, what's causing that? Let's look upstream and figure out, like, I can just give you a sleeping pill for your sleeplessness, but that's not really addressing the upstream cause. And it varies how far upstream you need to look. But what I'm encouraging us to do when we look upstream is not only to look upstream to perhaps the diagnosis that might be causing the symptom, but also to the structural and environmental conditions that might be predisposing a person to experience that symptom in the first place. So these aren't fixed definitions, but they're kind of a conceptual way that I see how people present. Jenny, what about you? What about upstream and downstream for you?
I resonate with what you've shared, and I really like that analogy too. And it reminded me of an elder that we work with very closely, Elder Jerry Ullman at PHSA, and he uses this analogy of the canoe, of this journey, whatever journey you're on, that recognizing you're not alone, that we're all in this canoe together. And so that visual came up when you reminded me of that, of whether you're going upstream or downstream or wherever you are, whoever it is in the system, that it's this journey that we're on.
Thanks for that. The next question is, how do you balance personal responsibility, which is a part of many programs out there, with the overwhelming impact of the environment on people's health?
I can start by sharing something on that. So I dedicate time to systemic advocacy. I work, it's in my bio, I think, on the website, but I actively work on system reform. And that for me is a really important way to feel more empowered when I see people who are in the healthcare system experiencing ongoing adversarial circumstances or systems that just aren't working well for people. It motivates me, and I found a place where I can act. And that means, I'm on the board of various nonprofit organizations that I try to do some leadership work where I'm able. And that work feels very important for me to balance and move forward system work. And so I'd encourage everyone to really take seriously opportunities to be advocates in their healthcare environment.
Yeah, and I think from a healthcare professional point of view, like if you are a regulated healthcare professional, now that you have awareness that the regulatory bodies sign on to this declaration of commitment, you can just explore, like, what is your college doing now with this commitment? Or if you're working in a healthcare system and you know that these declarations are made around the cultural safety and humility, and you're working in a healthcare system, like, what does this actually mean and look like in practice? So it can open the door for conversations around this, and also knowing that there's that organizational accountability. So it's no longer necessarily a personal responsibility, but it's the organization and the healthcare regulators' responsibility and accountability for this work as well.
Thanks for that. We'll go to the last question, and Jenny, I'll address this one to you first. The attendee asked, can you speak further on the differences between creating cultural safety versus baseline general safety as clinicians?
When we're talking about cultural safety for Indigenous peoples, it's actually very unique because when we start approaching and we see what resistance looks like, that will often be one of the areas. And if you went back to one of the slides that had that whole spectrum of like cultural blindness, where we say, well, safety is important for everybody. But if you look at what are the factors involved to promote cultural safety specifically for Indigenous peoples, it's the hundreds of years of colonization of Indigenous peoples. It's the health outcomes and social outcomes where Indigenous people are overrepresented. Depending on what framework or lens you use, you can identify this as a crisis situation, that Indigenous people and outcomes are in a crisis state. And again, it doesn't really matter which social issue you look at, which health issue you look at. You can look at the missing and murdered Indigenous women and girls, and even the impact of that on health services as well, and public health. So these are all interconnected and interrelated, that these issues are very systemic and entrenched in our society, that have to be addressed and changed. And that's really what cultural safety is all about, is addressing at all levels for Indigenous peoples.
And I would just add that safety is not the same for two people. So when I think of general safety, there's certain principles like slowing down and giving choice and control back to a person that can be kind of general principles that you can abide by in clinical work. But what feels safe for every individual patient is going to be different. And the way I see cultural safety work as well is something that is it's specific and it's unique to the Indigenous population in Canada, which is speaking up for safe practices that would be meaningful for them. And so the way I see it is that, and an example might be like for women giving birth, some women might feel safer at home and some women might feel safer in the hospital. And we just don't want to guess or presume what is the safe choice for that person. And so following guidelines for cultural safety, and also recognizing that in a safe relationship, we can explore what feels safe for each person in the care that they wish to receive.
And I'll just add a note. I've been involved in a lot of groups and committees that talk about creating change in a culturally safe place for Indigenous peoples. And one of the things that we always remind everyone there is that if we can create a system that's safe for Indigenous peoples, it'll be safe for everybody. So it's actually for the greater good of everybody.
I like that concept too. It's about trickle up rather than trickle down. And there's some, one thing that has really inspired my work is really recognizing what has been described as the law of inverse care, that the people who are most able to access care are those who access it the most, and they're often those who are not necessarily in the greatest need. And so being attuned to that and tailoring services for those who are in need and experiencing worse outcomes is really important work, and that the benefits can trickle up, but we must be conscious of our trickle-down approaches as they manifest in healthcare.
Kendra, I can see you're nodding your head. Do you have a follow-up question for Jenny and Vanessa?
I have really, really appreciated this. Thank you so much. And I just wanted to ask, so you talked a little bit about, particularly around kind of the health system commitment at a leadership level and professional bodies at a leadership level making commitments. And I feel like probably lots of folks in the audience, and certainly myself, and I would guess you as well, they're very big systems to create change in, and it can feel kind of painfully slow at times. And so I'm just really wondering if each one of you would be able to point to something that's making you feel really hopeful, or that you're seeing kind of shifts in movement right now. I would certainly appreciate that.
One thing that comes to mind that I've seen that's helped to have conversations around this is some of the work that the First Nations Health Authority is doing. So if you go to their website, they actually have these printouts that you can make that where an individual can actually make a commitment around cultural safety and humility and what that looks like. So I think there's resources and supports at the individual level that people can access. And in terms of sort of promoting hope and optimism, I think that in 2015, there's so much momentum that's happened socially and in health that it's really it's definitely a climate of change that I feel is happening. When I think about where I was working in the healthcare system, 10 years ago and where it's at now, even the number of changes that are taking place, it gives me great hope that change is happening.
Mm-hmm. And I think for me, again, it's been a really slow-moving process, but we're finally talking about primary care reform in BC, and with that, it will hopefully offer us is more access to team-based support, so just like a bigger basket of support to support those patients in need, and also alternate fee models, because so much of healthcare is rushed, and so much of it is procedure and intervention focused, and I really think that doesn't create safety for a lot of people, or even just doesn't provide patient-centered care. Like, it focuses us downstream because that's the way the payment model is incentivizing our care. And so that is shifting. And also, I'm co-chairing a committee with the BC College of Family Physicians that just started a social determinants of health committee, and we're really hoping to create some momentum and support for the new primary care models to have a social determinants of health lens and to be able to directly address social and environmental conditions that affect patients accessing these new networks of care. And now is really the time to be acting on that. And then the other last thing I would add is just that, you know, creating greater safety and healthfulness in your workplace has really profound benefits for patients. So it's really hard to create, you know, safe and healing environments for patients if people are really stressed out in their workplaces. And so there's ways that you can act to make for a better workplace, for example, that might be a good place to start and really safe and accessible. Just talk to people in your team, figure out how you can build greater support and build resiliency amongst the healthcare team to then increase the capacity to be able to be with patients who have multiple barriers.
Thank you.
Well, thank you both so much for being here and sharing your experience and expertise. And thank you everybody who joined the webinar. A quick mention before you sign off, you will find a short survey in a pop-up window when the webinar concludes. We greatly appreciate if you would take a minute or two and fill out the survey. Your feedback will help us design future policy webinars that address topics that are of interest to you. So that's all from us. Thank you so much, everyone. Enjoy the rest of your day.